Now we'll move forward to the next sixth session, which is part 2 of clinical perspectives in ABOi incompatible liver transplant. I would like to call upon stage a chairpersons, Dr. K.R. Vasudevan, Director, Department of Liver Transplant, JP Hospital, New Delhi. Dr. Sanjay Khanna, Consultant Gastroenterologist at BLK Hospital, New Delhi. Dr. Rajesh Tay, Consultant CLBS Max Hospital, New Delhi. And Dr. Hitendra Garg, Consultant Gastroenterologist at Indraprastha Apollo Hospital, New Delhi. The first topic of this session is lessons learned for ABOi incompatible kidney transplant. So I'd call upon stage Dr. Dinesh Khullar, Chairman, Department of Nephrology and Renal Transplant Medicine at Max Hospital, Saket. Please, sir.
Well, good afternoon, everyone, and thank you, Sanjeev. Thank you, Subhash, for this wonderful opportunity. I will start with a word of caution, and that caution has a basis to it. When Sanjeev told me to prepare a talk for today, he told me two things. One, it is going to be a plenary session. We are going to honor you, standing ovation, and no question and answers. And I was about to enter, he tells me, there will be question and answers. The second thing which he tells me is, liver walon ko ABOi incompatible nahi aata. And here I find my namesake knowing much more than what I do. And my slides are going to look like childish, and they are going to be as if ki koi MBBS class ho rahi hai. And please do pardon me for something which is going to be very, very basic, because if anyone has to be blamed, it is going to be Sanjeev. And the caution concludes by saying that don't even trust your closest friends. So I actually stand here because of the reason that we as nephrologists started little early, and we believe that we may know little more than our hepatology or liver transplant counterparts. But as has happened with the immunosuppression related to transplantation, we know very soon we will be just close to the starting line and the counterparts will be much ahead. I actually come here to learn from you all, and I've told my colleagues back in the department, please unwind whatever I learned from the liver colleagues today, because that's not going to help. It's like saying कि हमें बताया गया है कि वो लिवर वाले वहाँ पे तो एडवोकेट करते हैं, दूसरी मंजिल से छलांग लगा दो, कुछ नहीं होता. हमने भी छलांग लगा दी, talking about the immunosuppression, and we burnt our fingers and we had bad fractures. So what I want to say is they are different. So it's a Mars and Venus kind of thing rather than two identical things. So please take whatever I am going to tell you over the next few minutes with a pinch of salt and try to adapt it to your clinical practice, because we accept the fact. I used to argue a lot with Subhash. क्या करते हो? ATG नहीं देने दे रहे हो. Is a high risk patient तुम्हारा, zero matching, क्या कर रहे हो? Matching कराते ही नहीं है. And he will never allow me forget about ATG. वो तो Basiliximab भी अपने हैरान से. So for the first 5-6 years, I was quite skeptical, and I have to accept the facts. And Subhash was right. And the same go, I think, as I said, whatever we may have learned will probably need adaptation to the kind of scenario. And it's not a rule which says that, okay, you cut down by 50%. I think you'll have to do much more homework. Learning from our numbers, we definitely have more numbers. We have done close to about 200 transplants, ABOi incompatible. My first was way back in 2013 while I was at Sargangaram Hospital. We struggled, and we didn't even know then as to what can rituximab do. Rituximab caused a positive cross-match, and then I was worrying after giving rituximab, I was waiting for another donor, not realizing it's rituximab which is giving a positive cross-match. And only when the famous Dr. Denis Glotz from France came and said, stupid person, you just forget about it and go ahead with the transplantation. Well, I think we'll skip the basics. We'll skip from the kidney transplant point of view as well. It's been a long journey, but then initially people of course, burned their fingers. They knew that ABO is incompatible. No one would have dreamt, and I know Dr. Professor Chug, my mentor, the famous Professor Chug from PGI Chandigarh, father of nephrology in the country, would definitely fail anyone if he has not said the contraindication to a kidney transplantation is an ABO incompatibility. So it's only we used to learn from talking about the history from what the Japanese told us, and that was all after splenectomies. But to all credit, and I think against all odds, Dr. Gandhi, you may not even heard, he's a very famous nephrologist from Bombay at Beach Candy Hospital. He's been doing ABO incompatible transplants since 2005 and 6 with a decent result. I won't say great results, but then that was when we did not have immunoadsorption available to us, and still he had a very innovative way of going ahead and with a reasonably good success. But now we are much better off. After having had some bad results, we as a community have evolved and we are much better off than what we were about 10 years ago. So as I said, in India, it's been since the spurt came, ever since glycosol became available to us. At Max, we did our first transplant the year myself, my team, and Dr. Anand Kumar as a team joined here, and we did our first. We burnt our fingers, and we were figuring as to what happened to that first patient. A huge setback. We lost that patient, but subsequently we gathered, we mustered courage, and the results have been quite good. And I begin by saying that if our 1 year survival of kidney transplants is about 97 to 98% across the years, of the ABO incompatible, 1 year survival is 94% difference. Yes, but not huge difference numerically, at least. 204 over the last 10 years. But if we are going to discuss, and I thought the discussion should be on these lines, where we can talk from our experience, the kind of titers we have in mind, desensitization protocols, induction, immunosuppression, post-transplant monitoring, the important thing of accommodation, and long-term outcomes. So talking first about the titers, just a line to suffice that it's the IgG we are worried about in IgM. Very seldom do we also give importance to IgM. If there has been a recent spurt in IgM, take it with caution. Well, we initially were using tube dilution that has observer variation. So we are now pretty much happy with the better, which is more automated, and that's the gel agglutination method. We don't have, but I'm told if you read the literature that the flow cytometry is of course expensive, but then, and it's not easily available, but the best way to measure, to monitor the titers of these patients. Now, typically, we started off by thinking that ABO incompatible transplant is a very highly sensitized. No one had really dreaded that path till then. We took it as patients who were from different planet, and we had to be really aggressive. 500 milligrams of rituximab initially, and ATG on top of that. So you are depleting practically all B cells and T cells of them. And thankfully, we didn't have too many bad infections initially, but then cumulative incidence of infection was high. That is when we thought maybe we don't need 500, because even if you follow them up, the CD20 counts, as is our experience with other scenarios, other diseases, it doesn't come up for many, many months. So if we are happy with 100 milligrams, then I think the settlement was at 200 milligrams. And of course, we start not at day -7. We have time. We have dialysis to our rescue. So we can plan our patients, these transplants in a much better manner. And we start from 2 weeks prior. There are a few centers which start 1 month prior to the actual transplantation. Now, these are the various modalities. We use plasma exchange. I'll come back to that. And of course, the more talked about, that's immunoadsorption. And I think it probably would be a better thing to do in your patients where already coagulation is giving you trouble. So immunoadsorption is like just that Sanjeevani booty which Hanumanji is going to pick up rather than the whole pahad. So I think we are much better off with IA rather than plasma exchange, which takes away many other things, as you all know. We are happy at anything less than 1:8. Japanese say that we don't bother even about 1:32. Dr. Tanabe is a very famous person. The first name which comes to mind when we are talking about ABOi incompatible transplant in the setting of renal transplantation. Um, so Subhash has something to tell about Tanabe. I will definitely. Okay, great, thanks. So they don't fear even 1:32. Now, it's not just about number games because there is enough data. There's a very beautiful article in World Journal of Transplantation 2020 which says, don't be misled by titers, either pre-transplant or post-transplant. And I will certainly come back to that aspect. We used to believe we could venture subsequently after a few success stories into a patient who had a baseline titers of 4096 and used 3 columns, and that guy is still doing very well 10 years down the line, 9 years down the line. So double filtration, we have had a couple of patients put on double filtration. What it does in the series, you have 2 filters so that one gets back. It's on the lines of immunoadsorption, so probably doesn't allow the wastage of too many good things. But yes, if your patient can afford it, I would any day recommend immunoadsorption. IVIG, again, there was skepticism because people thought this is one way of transmitting isoagglutinins. So you should be wary about usage of IVIG as well. So if you have to use IVIG in your patients, probably the best thing to do is use little early rather than just at the time of the transplantation, because then probably while you are going ahead, the titers may actually go up. I, for one, has been a huge fan of ATG. We did a lot of work on thymo in the context of kidney transplantation, starting way back in 2003. And as you can see from the enthusiasm, big fan of thymocyte globulin. But I must accept the fact that things did go wrong when we used thymoglobulin as the only induction therapy initially. It was kind of mixed. 5 patients on the trot, nothing will happen. Then suddenly 6 will have an exponential increase in the titers and will lose the graft. So someone suggested that maybe ATG induction is giving the abnormal antigenic stimulation. So for the last about couple of years, we have refrained from using thymoglobulin as the induction therapy, and I don't know whether it is of any significance to you all, because I don't believe liver surgeons, hepatologists use too much of thymoglobulin as an induction. I'm not talking about as anti-rejection therapy. So, but please keep that in mind. We have burnt our fingers, but the literature, the jury is still out. Literature doesn't give me a clear-cut answer. There are enough Western literature which says just go ahead, use a smaller dose of rituximab, use a smaller dose of ATG, but then go ahead. Infections, of course, is important to us, but they are much more important to you. So keep that in mind. Basiliximab is something which we always use for 2 reasons. One, we don't want to give as potent induction as ATG, but we still want to give, still fearing that they are high-risk transplants. And for the second reason is medical legal. I mean, when you use them, you are in trouble. When you don't use them, there are enough number of people trying to guide you as to why didn't you use this is a high risk. Why didn't you use any induction? Although we have tried. My colleague Dr. Rahul Grover has a fantastic experience. He said, I'm not going to use any kind of induction. I'll just use rituximab. He had fantastic results in transplantation for good 10 cases. So as I said, the jury is still out. Methylprednisolone, of course, that's what we standard use. No, we begin 2 weeks prior. We give the 200 milligrams of rituximab, and that is when we start both tacrolimus and MMF, 0.1 milligrams of tacrolimus per kilo in 2 divided dosages. And we then sorry. No. So this is post-operative, sorry. So post-operative, we monitor these titers regularly for 2 weeks, twice daily for the first 7 days and daily for the next 7 days. Even though literature says you shouldn't be overly worried about a rise in titers post-transplantation if the graft function is normal. I think any increase beyond 2 logs gives us jitters. And I think even in the morning, if we decide not to go ahead with the plasma exchange, we find ourselves doing another exchange by the evening. Now, accommodation is a very interesting concept, and I think this is more applicable for the renal transplants, because we uh, get into a lot of trouble post transplantation trying to figure out what went wrong when we have graft dysfunction, whether it is rejection, whether it is CNI toxicity. So we rely very heavily on C4D positivity, and we know that because of accommodation, C4D becomes positive and it's just there on the surface of the graft. But if it happens very early, our pathologist, who is brilliant, Rajan Duggal, tells us that if you on day one itself you have graft dysfunction and you have C4D positivity, this is acute rejection, not accommodation. Accommodation takes time, needs time. It happens in about week 10 days time. So this is the importance of C4D, which we give a lot of importance to differentiating chronic graft dysfunction from chronic rejections. So I think you can again adapt to your scenario as well. The timeline of accommodation, the first 48 hours is a silent period, but we generally should be careful for the first 3 weeks. Precisely, the day 7 to 19 is very crucial as far as experience has told us, and subsequently it is a stable course. So far, we believe this C4D positivity doesn't do anything, but I don't know what the literature subsequently is going to tell us. Now, coming to the areas of interest, we don't want to lose a precious graft, and of course, it's the stronger case in your case, I would believe so. But you still can have antibody mediated rejection, and there are two types. One where we can't do anything. This is something which probably happened in our first patient. We blamed the lab as to you gave us wrong titers, but then probably I accept the fact it must have been the type 1 antibody mediated rejection, which is dependent on antigen stimulation, and of course the type 2 is more on the immunological. So type 1 is where you have an exponential increase because of the exposure. You have the exponential increase in the titers. No matter what you do, you will end up losing the graft. This is what I have to admit in 2023. But when you talk about type 2, you should try your level best. So here the situation will give you time. We fight it out, and quite a lot of times we do gain success. Well, we are all familiar with the complications. The intraoperative bleeding complications are going to be higher in your patients. And of course, we have that uniform protocol for the antimicrobial prophylaxis. So I'll end up saying that the outcomes are comparable. It's only the first 2 weeks which give us trouble. Beyond 2 weeks, the ABO compatible and ABO incompatible behave similarly. So, but the first 2 weeks keeps you on your toes. Any increase in the creatinine or the titers will certainly give you shivers. When the of course the points to ponder are, if we allow our patients to continue on hemodialysis, saying that you don't have an ABO compatible donor, look at the poor results. 50% survival over 5 years. And if you look at highly sensitized, the survival is patient survival is less than 90%. While if we go back and see, as you can see here, 1 year graft survival in both exceeds 90, whether it is ABO compatible or ABI. So our results are something comparable. I didn't have the time. We are in the process of compiling our data, but let me assure you, it is on the similar lines what I could get from the world literature. So of course, while we are talking about ABO incompatible transplantation, I would any day be an advocate for KDP, paired kidney donation, swap, domino, whatever you may have in mind. So it is only when that is not possible should I ask my patient and the family to go in for an ABO incompatible transplantation. And I'm open to, much against my wishes, I'm in that jhansa which Jeev gave me. I'm open to questions. Thanks, everyone.
So please, will you tell us a bit about this AMR type 1, type 2, because there's a new concept to liver people.
Yeah. So there are two kinds of things. One is the antigenic stimulation, and one is the immunological response. So what we have is the type 1, whereby probably because of, it could be memory cells, it could be whatever, the moment there is an antigenic stimulation, there is an exponential increase in the titers. You will find a baseline titer of 1 is to 16 or 1 is to 32 suddenly goes up to 256, 512, and 1024. And of course, you will be very quick to prompt to start plasma exchange. And here we believe post transplant, we use less of immunoadsorption and more of conventional plasma exchange. That's what the standard practice is with us. But no matter what you do, you end up losing the graft, and we believe it's because of the antigen. The second variety is a few days later, it's probably, we believe, in response to infections, typically UTI, which stimulates, and the titer increase is not very exponential. It gives you enough time. It's a slow, indolent course, and we are able to manage it better.
Not clinical terminology or based on pathology?
There's a clinical terminology. There's clinical.
I think Dinesh, you got a fantastic talk, and I must say that if I have to say lessons learned, well, of course, you always learn things, Like, I mean, I can actually make a comparative table between kidney and the liver group, and actually have a couple of points which are different. Like, you would use basiliximab with induction, liver we will not use. Now, you will not face things like ALF, ACLF, which we face in our group of patients. Titer was probably similar. 116, 168 is a similar thing. What AMR, Dr. Gupta said, we don't really, honestly, we have not. So that's a learning point. So we should go and ponder, talk to pathologists. Is there a...
Sorry, I'll interrupt here. So, Bhash, you would remember, initially, no one from your side ever thought that your people have too much of AMR. And then you did realize that, yes, you do also see chronic AMRs. So I think probably you will need to see more and more of these, because as I said, on the trot, nothing would happen. Suddenly, the 10th patient will shatter your confidence to an extent कि घर आके आप बोलोगे करूँगा नहीं दोबारा कभी, ABO incompatible. So I think with the increase in the numbers, you people also are going to see some AMRs.
So tell me, what is your frequency of kidney biopsy to detect or diagnose AMR post ABOi transplant?
We are trigger happy. We do a lot of biopsies. So I think whenever anything goes wrong within the hospital stay itself, there could be 1 or even 2 biopsies. Anything going wrong in the first 1 month, 2 months, we as I confess, we are trigger happy. So we do a lot of biopsies.
Sir, as an extension to in the same vein, I would like to ask that when we look at ABOi in liver per se, there are studies, one from Korea and one from Japan, where they have shown that they initially used to do protocol biopsies. And you laid a lot of stress in your talk on C4D, but they said that even with normal LFTs, normal titers, you can have a finding of C4D positivity that to the tune of around 14-15%. So they say that C4D per se may not be that important. You cannot see it in isolation. You have to see the entire picture, and therefore, I'm talking of liver. I don't have any experience with the kidneys. So when we talk of ABOi liver, you cannot rely entirely on the biopsy findings. You have to take the clinical picture into account, and the biopsy may not lead or may mislead you at times.
No.
So-
I'll if I let me first, if I have understood the question, is that in the context of ABO incompatible,
Yes,
the
sir.
C4D?
Yes, sir. Yes,
No,
sir.
I think that was the point I wanted to make. Now, whenever we have an ABO incompatible transplant, 2 weeks down the line, C4D has to be there in each and every patient. 100% patients will have accommodation if that graft is going to survive. So what I wanted to say was, initially today, accommodation is going to take time. You do a biopsy on day 2, day 3, C4D positivity may not be there, and you did it for whatever reason. But by day couple of weeks or 3 weeks, definitely, each and every patient should have C4D positivity. What I'm trying to say is that if you have C4D positivity in the first day itself, think of acute rejection. So that's the other way.
Yeah, we
so
never do
so you
day one, day
don't
two
get
biopsies.
accommodation. So accommodation is the whole key. So what happens is, as we all know, so these isoglutamins are there on the graft surface. They're also circulating. So the circulating are quite notorious as well. So C4D positivity for us ordinarily as nephrologists means chronic rejection. So if the pathologist first thing he asks, is it ABO compatible or ABO incompatible? If it's an ABO compatible transplant and you see a lot of C4D positivity, it is a chronic
Because
rejection.
I'm talking only of ABOi.
Now coming to ABO incompatible, C4D positivity will be there, but then the very important point, we rely a lot on what the histopathologist tells. If there is a tubular capillaritis, I'll come back to that. So if there is a glomerulitis, if there is peritubular capillaritis, it is acute rejection. Right. So on top of that, if you have C4D positivity, now you will have to scratch your mind. Is it accommodation or is it? But those other pathological findings will tell us this is acute rejection antibody. And the problem is the even the tubular cells, they have receptors for the ABO antigen. So it's a problem can be there as well.
Say liver sepsis is the predominant cause of graft failure post ABOi versus rejection. In kidney, what is the cause of main graft failure?
It is in the context of AB incompatible. I think it's immunological. We don't lose too many grafts these days to infections. So that's our we thankfully because of the adequate immunoprophylaxis we are much better off. We do lose, but then seldom, I would say. We lose majority of our grafts for immunological reasons. And that's where we differ. I think that's our thinking actually is on different lines.
Can I ask a sort of
difficult question?
No, not a difficult question. We believe in liver because sepsis is so much there that we have to control sepsis. Rejection we can reverse in liver. But I think the kidney people believe that rejection cannot be reversed. So my question to you is, in ABO incompatible, should we still be continuing with the same thought that that just control the sepsis and rejection can be reversed? ABO incompatible liver, can we reverse it? Or that's an answer to this question I don't have. But for ABO compatible liver transplant, I can tell you, I say if you can control infection, that's why you and me keep having these debates whether to give induction, not give induction, and always say no.
I accept. I do, and it's in all seriousness, I accept that you were right. No question about that. Now, I will seek that answer from you. Over the years, you will have to tell me that you haven't seen any type 1 exponential type 1 antibody mediated rejections. Then you need to worry more about infections rather than immunological reasons. I think that's a huge contrast. And we fear less of infections. Kidney is much more immunologically active, and we'll be more scared. It's not that as if the rejections don't get reversed. Majority of the kidney rejections do get reversed, except for this type 1 AMR, which we see thankfully not very often in the context of ABO incompatible.
Dr. Kuller, you seem to have enjoyed the Q&A more than the talk. Maybe the next time there should be a Q&A first or only Q&A.
Yeah.
Thank you so much for sharing your experience.
Tell Sanjeev to warn me ahead. These were absolutely basic slides, and मुझे बोल रहे हैं कि liver वालों को ABO incompatible नहीं आता और यहाँ आके पता लगता सब कुछ आता है.
I must say, Dr. Kuller has supported our program. Otherwise, we would not have taken ABO 100 ABO incompatible without his
See, we felicitate you also.
I do deserve a cup of tea also. Thanks. Thank you very much.
Lovely.
And the best thing is you give me a chance to meet Dr. Savda. There's nothing could be.
Thank you very much, sir, for telling your pulse of experience from ABO incompatible kidney transplants. Now we'll move forward to our next lecture, which is on current organ allocation policy in ABO incompatible liver transplant. This lecture will be moderated by Dr. Sonal Asthana, Senior Consultant HPP and Liver Transplant Surgery at Esther CMI Hospital, Bangalore.
Thank you very much, Dr. Sehgal and Dr. Gupta, for this very kind invitation. It's nice to be here. So we'll change gears a little bit. We've talked a lot about ABO incompatibility, about the science of it, immunosuppression, but it's predominantly been in the context of living donor transplant. Deceased donor transplantation is a completely different animal, actually. Living donor and deceased donor have only the word transplant in common with them. The process of the performance of the transplant, the degree of injury, the way we accept organs, the way we transplant is completely different. And certainly, there are several other elements when we talk about allocation policy that should also be addressed. So I don't really have any competing interests here. This is probably sort of the first and the last slide. The TLDR means too long, didn't read. So in India, ABO incompatible is not allowed. In the UK, it's allowed for pediatrics. In OPTN, it's allowed in unusual situations, high mild. So I could stop the talk here, but obviously I have 12 more minutes to finish. So I shall fill that in with a little bit more detail about each one of these. So what is the difference between a living donor and a deceased donor transplant? Of course, in a living donor transplant, it's a directed gift. A donor is donating an organ to a recipient. It's somebody that's donating out of love and affection. If that organ is not utilized for the recipient, it's not available to anybody else. So nobody else is suffering. So when we talk about equipoise in deceased donor transplant, we have to see the benefit. Benefit means how many years would the person survive without a transplant versus how many years we give the patient with a transplant. The second is equity. Are we actually getting enough bang for our buck? So if this organ is actually given to somebody else, would it have lasted longer as compared to whether it was given to person Y? Are we getting enough out of that? So the standard accepted answer for that is 50% at 5 years. The third is maleficence, or maybe non-maleficence is the better word, where we talk about, are we actually disadvantaging anybody? If we are, say robbing Peter to pay Paul, are we actually disadvantaging a third person because the same organ should have been utilized by somebody else? So there are several other competing interests or competing ideas that come out when we talk about organ allocation. And certainly there's a big question mark when we talk about ABO incompatibility, because we have a clinical need, but there certainly is a case to be made for giving to somebody who would be ABO compatible and perhaps getting more out of that organ. In the long term, it should be a greater benefit to society. So what are the challenges? Firstly, the patient group is completely different in a living donor transplantation as compared to a living donor transplantation. Most patients who are allocated ABO incompatible transplant organs in a deceased donor setting are either patients of acute liver failure or acute and chronic liver failure. It makes sense because anybody who's stable on a waiting list can wait for a compatible organ. So the only people for whom you need to allocate an incompatible organ are people who are too sick to wait. Organs are usually marginal, especially in our country. Almost every single liver is marginal, no matter what the criteria say. All donors are poorly preserved. All donors live in an ICU for more than 5 days. And certainly there is a very high incidence of metabolic disease. So we have marginal organs from the get-go. All these organs have long cold ischemia times. Especially when it comes to children, we are splitting organs. So we're making a marginal organ even more marginal. There is no time for the elaborate induction regimes that we talk about, the -40 and -7. That's not going to happen because you have about 12 hours between an organ being allocated to you and accepting it. And of course, the logistics. Now you can look at this data from ILTR that has come out from between LDLT and DDLT. You can see that the cold ischemia time for a DDLT is almost 200 minutes on average as compared to an LDLT. Of course, this makes sense. But interestingly, even the warm ischemia time is higher for a DDLT in our setup. Because obviously we are much better at benching and reconstruction. We spend less time in warm ischemia. This just goes to show that probably the expertise in the country is actually significantly higher when it comes to a living donor. And a deceased donor journey is completely different. We are talking about a different degree of hypoxia and ischemia reperfusion to the organ. We start with an unwell donor who undergoes ischemic insult. Then the patient passes away. A living donor operation begins. There's injury. Organ is explanted, preserved, implanted, ischemia reperfusion, and the injury continues over days, months, and years. So we're not talking about a single point of ischemia reperfusion where an organ is retrieved from a healthy person and then implanted with a short cold ischemia time. We're talking about a completely different organ in a different context. So the primary questions of this talk are, firstly, what is the current policy? Secondly, are the results of ABOi DDLT the same as ABOc DDLT? And thirdly, is anyone disadvantaged by this allocation? So suppose we change allocation and we say that we want to favor people who are being disadvantaged by the system. Are we actually taking from one hand and actually giving it to another hand? How are we sort of cutting off our nose to sort of spite our face, I guess? In India, I think ABO incompatible allocations are not allowed. I'm sure Dr. Srinivas will talk about that in his slide as well. We have had exceptions where we have allocated, but these have been exceptions rather than rules. They've been allocated in Tamil Nadu in the context of split livers in a few occasions. In Karnataka, in the last 7 years, we've had only one allocation that was done for a primary non-function after unanimous consent from all centers. It's not going to happen today because the number of centers that has increased so much that I don't see this happening again. So currently there is no law and there is no planned way in which an ABO incompatible transplant can happen in a DDLD setting unless there is unanimous consent or pressure or decisions made at a collective level. In the UK, there is an allocation sequence. This is the relevant part of the sequence. A BG incompatible pediatric donation can happen for pediatrics, for children who are less than 2 years of age. Okay. There are different, obviously, stratifications for this, but the only context in which an ABO incompatible transplant is allowed by the UK and HSPT is for children less than 2 years of age. When we talk about the OPT and UNOS, now this is much more complex. I'm just trying to break it down. It's usually for status 1A and 1B, that is sick patients. Patients who have a high MELD or PELD score. And of course, there are different stratifications between that as well. So we have an allocation MELD score. We have blood group incompatibility, identical, compatible, then incompatible. And then there are different allocation points calculated by age at time of registration, the allocation score, as well as the waiting time. So these are all given some numeric scores by which we get a collective score by which organs are allocated. So when we talk specifically about blood group allocation, you can see that the system is designed to discourage ABO incompatible transplants. Patients for status 1A and 1B, that is acute liver failure, same blood type will receive 10 points. Compatible receives 5 points. Incompatible receives 0 points. Okay, so they actually try to make sure that incompatibles are not considered in any way, despite some do get through the net, as we'll see in the next slides. So why is this difference? This is probably because the initial part of the data was very, very dismal. We had some very disastrous data coming from Canada. There was one paper that came from Christian Toso. This actually looked at about 14 ALFs who had received an incompatible donation from Edmonton, and this was comparable to ABO incompatible transplants. And there was another paper from the University of Toronto, again looking at an ALF cohort, which showed an 83% retransplant rate for ABO incompatible. Obviously, that data was not encouraging at all when we came from an allocation perspective. This paper came from the Hopkins group when we looked at about 1,000 patients over a 16-year period, distinguishing infants, pediatrics, and adults. And then they found that actually the survival had improved despite the ERA efforts, but it was much worse for adult ABOi as compared to adult ABO compatible. But when it comes to infants and pediatrics, they actually did well after ABO incompatible as well. So the specific things that make a difference. Infants and ERA effect was actually very evident. Transplant done after 2000 or a donor age of less than 9. Pediatrics, a female recipient age, sex, and donor age greater than 50 years. And adults who were very sick. I mean, this is again, goes to the question that you are transplanting people who have ACLF or ALF, so they will be on life support or not be well otherwise. And as again, you can see from this graph, the biggest drop-off is in the first 3 months. So most of these patients are lost in the early part of their experience. The long-term results seem to be roughly comparable. When we look at children, again, this is European data, we find actually that the results for ABO incompatible transplants are significantly worse than ABO compatible transplants, regardless of the era. So the second graph is between 2011 to 2018, and this is the graph before 2010. Okay. Sorry, I took a slide, did I? Sorry about that. So, okay, then looking at a little bit more sort of, recent data about emergency transplants for ALF and ABO incompatible patients. This is a relatively small cohort of patients, 20 patients where they have comparable survival. But I use this paper to predominantly point out the induction regime. So they started immunoadsorption as soon as a DDLT was identified. They did 3 elective sessions on day 2, day 5, day 8. And for the first 2 postoperative weeks, they did immunoadsorption if the titers level increased more than 2-fold. I think last time they were talking about 2 log, but they probably meant 2-fold distinct, if I understood it correctly. 2-fold, right? They've used a very high dose of rituximab. Previous to 2014, some patients received ATG as well, received IVIG. very high doses of tacrolimus MMF and prednisone 100 milligrams PD. So clearly a lot of immunosuppression. This is something that we could not think about in our setup really. And finally, the last part of the talk, which is the disadvantage of ABOi incompatibility. Now, are we actually taking this organ away that could be used potentially for somebody who could last a longer time and maybe benefited longer? Well, organs are national resources. We have to sort of look at allocation of organs in a way that can maximize their utility. So there have been some efforts to use organs in order to promote equity. So this is actually a paper from a kidney group, from Nizam Mahmood's group in the UK, where they realized that patients who had blood group B in the UK were disadvantaged when they came to kidney allocation. So they proposed an A2 to B allocation system, by which A2 organs, which are a little bit more common, could be utilized for B recipients, which are actually more in immigrants and who were actually traditionally disadvantaged groups in the UK. So they actually found that A2 to B allocations. They did a study based on world data, and they proposed a system to improve the equity of organ allocation. But what happens in our setup? So this is the waiting list in Karnataka. Right now, 1,400 patients are waiting for a transplant. 38% are blood group O, 25% are A, and 30% blood group B. Right? So if, for example, we get a blood group O organ and we utilize it for other blood groups, non-identical, we will disadvantage blood group O patients. Similarly, any blood group that is moving, suppose we do B to A, what happens to the 400 patients in blood group B? So we did some of our own work on this. We looked at our own data from over 3 years. We listed 207 patients. We transplanted 36% of them. The median waiting time was 179 days. The median waiting list for O blood group was 244 days. Patients died in the waiting list after waiting for 100 days. And of course, the patients who died had a higher MELD. So when we look at our own waiting time, we find that a good portion, almost 30%, 33% died while on the waiting list. So in this sort of context, it's very difficult to justify using an organ that could be used to save one of these patients for somebody else who was very, very sick. So certainly the balance that we need to do is going to be a little bit more complicated. Again, this has been addressed in the UK in this paper in 2016, where they looked at all non-status 1 patients, that is non-ALF patients, who received non-identical liver transplants. And then we found that non-identical transplants happened in 2, 3, 20, and 36%. Not surprisingly, blood group AB recipients got patients from every kind of donor. And there was a net loss of livers from blood group O and type A, and net gain of livers in blood group AB. So AB was advantaged, but O and A were disadvantaged. So O and A are common blood groups. Patients who are waiting on the waiting list will wait longer. So is it actually fair on them? And that is something that a allocation system should be addressing. So to summarize, we have a different patient group when we talk about DDLT for ABOi incompatibles. It's usually done for acute liver failure and acute and chronic liver failure. We do not have time for elaborate induction regimes. So the regimes are actually very, very different, and they are done in the context of a sick patient. So for example, just to give you an example, the immunoadsorption was done with 7 liters of plasma exchange. That is not going to be possible in a patient who is hemodynamically unstable. The results are worse for ABOi incompatible transplants as compared to ABOi compatible transplants. And current allocation systems across the world only allow allocation in exceptional circumstances. And predominantly because apart from the worse results and apart from the clinical context, we should also keep equity in mind. Thank you so much.
That's a lovely summary of the policies available to ABOi incompatible organ allocation. Open for questions, please.
I think, Sonal, you have done justice to the talk which you've given. Just to add that, I think we designed a talk for ABOi incompatible transplant DDLT. I know that's a very difficult challenge. One is an organ allocation issue, which is itself a big problem. And then if you are actually contemplating it, how do you bridge that, huge barrier of incompatibility? So I think somebody's going to speak.
I deleted half my slides because I found that Dr. Srinivas was
So I think
going to be using that.
So it could be like part A and part B, you giving the organ allocation thing and with giving the thing too. We probably have a very good coverage of this very exciting topic. So I thought I'll just make the audience aware of this fact.
Sure. Thank you.
If you had to make one change to the organ allocation policy for ABOi incompatible, what would that be?
I mean, in the Indian context, it's a very difficult question to answer because our donation rates are so low as compared to the requirement. It's easy to do in Scandinavia because they have a very high donation rate. They have waiting lists of 1 month, 1.5 months. So for them, it's not difficult. Similarly, now I mean again, Mette will make that point in his talk. For us, a retransplant means death. Because when we have a organ failure, there is no safety net for our patients. So we have to think about all those things when we talk about ABOi incompatible transplants in our context. I mean, at this point, I think it's a little premature until we have decent donation rates. Thank you.
Can we close the session if there are no more questions?
Thank you very much, sir, for the detailed discussion on the topic. And thank you, chairpersons,